topic of hypoglycemia, we'll go just on an overview. We will not go into a detailed, talk, because the time will not allow us for much. So it will be just like a clinical approach, quick clinical approach, and how to deal with these cases. So here we are to start with.
Recording in progress.
And here, this is a flow of my presentation. It's like we start with definition, causes, symptoms, history and physical, and we go by clinical approach to the workup, management, and some case scenarios. So hypoglycemia is a blood glucose of less than 2.6 millimole per liter. Although there are some different definitions for this, and there is some controversy in this level, but it's the most agreed level for hypoglycemia. It's like almost equally 46.8 milligram per deciliter. And in diabetic, it's a little bit higher. It's less than 4 millimole per liter. So we are talking here about subjects who are non-diabetic. So hypoglycemia occurs when blood glucose utilization exceeds the supply. So, and that mainly will be seen during prolonged fasting and at the time of illness like vomiting and diarrhea, and with impaired counter-regulatory hormones or impaired errors of metabolism. And also will be seen in excess glucose utilization like in hyperinsulinism. So what are the causes of hypoglycemia? It's either reduce glucose availability or increase glucose consumption. And here there's some examples like intrauterine growth retardation, prematurity for the reduced glucose availability, and for sure small for gestational age, hypopituitarism, adrenal insufficiency, and growth hormone deficiency, and accelerated starvation. Accelerated starvation is usually also called like ketotic hypoglycemia. And we'll come to that, inshallah. And also important errors of metabolism. And for increased glucose consumption, we have hyperinsulinism, transient neonatal hyperinsulinism, and infant of diabetic mother, and persistent hyperinsulinemic hypoglycemia of infancy, and some syndromes like Beckwith-Whitman syndrome. So what are the symptoms of hypoglycemia? There are some symptoms we call autonomic or adrenergic symptoms, because not related to the peripheral system, is not the central nervous system. And there are neuroglycopenic symptoms, which are mainly central. So for the autonomic, in neonates, we find pallor, sweating, tachypnea, and tachycardia. And for the neuroglycopenic symptoms, we find like jitteriness, apnea, hypotonia, feeding problems, irritability, abnormal cry, convulsions, and coma, and others. That will be different a little bit from the infant or older children, because in infants we find like autonomic symptoms will be like anxiety, palpitation, sweating. This is in children, and tremors and tachycardia. Neuroglycopenic symptoms definitely like hunger, abdominal pain in older children, nausea and vomiting, headache, weakness, dizziness, blurred vision, and irritability, and sometimes it can reach up confusion. And also convulsions and coma, like a shared symptom. So there are important points we have to take care of when going history taking. Number one, you should ask about the pregnancy, the duration of pregnancy. Is it like a complete pregnancy, or there is a prematurity or something? Maternal symptoms suggestive of diabetes, like gestational diabetes. And also you have to ask about the mode of delivery, because they say that there are some cases of hypopituitarism usually present with breech delivery. And birth weight is very important, because if there's increased birth weight, we have to think about like macrosomia, which is known in infant of diabetic mother, and also in Beckwith-Whitman syndrome. And we have to think, and also hyperinsulinism. Or ask about decreased weight, you have to think about small for gestational age and IUGR. The maximum time, this is a very important point, the maximum time that the fasting has been tolerated, this is very important because some kids, they cannot tolerate long time fast. like we see in ketotic hypoglycemia, for example, and other inborn errors of metabolism, like glycogen storage disease and so. And you have also to consider the possibility of intake of hypoglycemic medication, either accidentally or non-accidentally. Accidentally, just like by mistake taken by the child, like it can take like metformin or other oral hypoglycemic medication, or an inflicted like factitious hypoglycemia, which is like giving the child insulin, and this usually happens by the personnel who is having access to these medications. Also, in family history, you have to ask about consanguinity and unexplained infant death, so as to think about inborn errors of metabolism. Also, you have to ask about symptoms of gastrointestinal symptoms like vomiting, diarrhea, jaundice, and hepatomegaly, on the failure to thrive. Usually, this will come following lactose and fructose and sucrose-containing foods. If you find that, you have to suggest galactosemia and fructose intolerance, and as in the differential. But remember, most of the patients with hypoglycemia usually do not present with over symptoms of hypoglycemia, and also sometimes will not have like apparent abnormalities in the history. Going to signs, also you have to take care about important clinical signs during your exam. You ask about look for optic atrophy, and this will suggest septo-optic dysplasia, cranial midline defects, and short stature or decreased height velocity, and micropenis. This will point towards hypopituitarism or isolated growth hormone deficiency. And also, you have to look for hyperpigmentation, and hypotension that will tell about adrenal insufficiency, like Addison disease. And you have also to examine for the parameters to see if there's underweight or malnutrition. And this will tell you about accelerated starvation or sometimes some cases of ketotic hypoglycemia. Tall stature or increased height velocity usually goes with hyperinsulinism, macrosomia, hemihypertrophy, and abnormal earlobe, like transverse ear crease, and macroglossia, umbilical hernia. That will tell you about Beckwith-Widman syndrome. And you have to look definitely for hepatosplenomegaly because it's an important sign in glycogen storage diseases. So in the clinical approach, you have to have if there are suggested symptoms of hypoglycemia, as we talked just a few minutes ago, you have to do a rapid blood glucose determination. If you find hypoglycemia like less than 2.6 millimole per liter, you will go to give glucose at the moment, and then you proceed. For intermediate levels like 40 to 70 milligram per deciliter, you have to repeat the sample to make sure that there is hypoglycemia or not. If there is no hypoglycemia, no proven or no confirmed hypoglycemia, you have to evaluate for other causes like hypocalcemia, hypomagnesemia, hyponatremia, and don't forget primary CNS disorders. Talking about if there is hypoglycemia is confirmed, we have to go in two different ways at the same time. Continuing physical and history and physical examination, and at the same time you take like a critical blood sample, which usually taken during the time of hypoglycemia. If you didn't cut the first sample after the first attack of hypoglycemia, the next hypoglycemic episode should be taken as a chance to take this critical sample, and that will come later. But about history and physical examination, you have to look, as we mentioned, for a cause which discussed a few minutes ago, prematurity, small for gestational age, and maternal diabetes, because usually these can present with transient neonatal hypoglycemia, or which we call transient neonatal hyperinsulinism. And this is also usually occurs in small for gestational age due to perinatal stress or asphyxia, and seen frequently also in the cesarean section deliveries. You have also in these cases of transient neonatal hypoglycemia, you do like feeding tests. You give frequent feeds. If it's responsive, that means mostly will be transient. If there is the hypoglycemia has been treated by these feeds, but some cases might need diazoxide for a while, and usually they spontaneously resolve at the age of 6 months. And the cause of hypoglycemia here is hyperinsulinism, but it's hyperinsulinism that is responsive, not like the persistent hyperinsulinism, which is not responsive. This is a transient, which is responsive to frequent feeds, and here the mechanism of hyperinsulinism is not known really. So next, you have to look for jaundice, micropenis. Jaundice, I was talking about persistent jaundice that is continuing more than 14 days, and with other signs like in history, like preach delivery, and then you have to think about hypopituitarism or isolated growth hormone deficiency. And here you have to take samples for, you have to treat with growth hormone and thyroxine and glucocorticoids like cortisol or hydrocortisone and fludrocortisone and others. So continuing in other causes, if you find macrosomia but no maternal diabetes, think about hyperinsulinism, either transient or persistent hyperinsulinism of hypoglycemia of infancy. Also, if there is macrosomia with maternal diabetes, here think of infant of diabetic mother. And if there is the syndrome of macrosomia, macroglossia, earlobe, fissure, you have to think about Beckwith-Whitman syndrome. These are the main causes which can be picked during just history and physical examination. But there are many causes of hypoglycemia that will not be over. You have to do the critical blood sample that will tell you much details about the cause of hypoglycemia. You have to take insulin, growth hormone, cortisol, free fatty acids or esterified fatty acids, and beta hydroxybutyrate, lactate, and urinary ketones. And these are very important to be taken during the attack of hypoglycemia. You take these blood samples, but the urine, you can wait for the first void after the hypoglycemic episode. You catch the first void after this episode, that will tell you much about the diagnosis. Because the main point here, we have to differentiate, is it ketotic hypoglycemia or non-ketotic? That means, are there any ketone bodies in the urine or the blood? If there is ketonemia or ketonuria, will if there is no ketonuria or ketonemia absent or low, that will tell us about different things. We'll come to it later, like hyperinsulinism and so. But if there is present moderate or high ketone bodies in the urine or blood, you have to take here growth hormone and cortisol levels. If you find the growth hormone and cortisol are low, you have to do ACTH stimulation test. If you find like low ACTH, think about hypopituitarism. If you find high ACTH, think about adrenal insufficiency, because that straightforward way to reveal the difference between higher centers pituitary problem and the adrenal issue, the ACTH stimulation. But what if it is like only you have growth hormone and cortisol normal? Then you will go in this pathway. If you find normal growth hormone and cortisol, look for hepatomegaly. Is there hepatomegaly or not? If there is no hepatomegaly, this is mostly ketotic hypoglycemia, and usually this presents at the age of like 16 to 18 months. And usually males are more prone to it than females. And usually it resolves by the age of like 7, 6 years. It looks like febrile convulsions. They have the same criteria, but it can resolve up to puberty. If there is lactate in the after you find there is like hepatomegaly, you look for lactate. If the lactates are high, so think about glycogen storage disease. And for glycogen storage disease, we evaluate enzyme activity in the blood and also in the liver. And usually you find like lactic acidosis, in which you find the pH is less than 7.35 plus minus an ion gap of 15 milliequivalent per liter or above. Also, you take urine for organic acids. If there is no urine, no positive urine for organic acid, that means this is acute illness in a normal child, otherwise normal child. But if there is organic acid, this is mostly organic acidemia. So, but if there is no ketones, it's non-ketotic. So here we come to this pathway. You have to do like urine non-glucose reducing substances. That's clean test. The clean test, if it's positive, the clean test if positive, and at the same time the clean sticks is negative. Clean test is positive for non-sugar, non-glucose reducing substances, and clean sticks is specific for glucose. So if the test specific for glucose is negative, and the test which is specific or sensitive for reducing substances other than glucose, here we have to think about hereditary fructose intolerance or galactosemia. If there is no reducing substances, here you have to take the insulin levels to see if the insulin levels are elevated or not elevated. If the insulin levels are not elevated, here if you have to think about defects of fatty acid oxidation or carnitine deficiency. And but what if the insulin levels are elevated? Here the issue, you have to take like the specific level of insulin. If the insulin level is more than 5 to 10 micro unit per ml, we have to do fasting glucagon test. And the fasting glucagon test here we applied by giving glucagon injection, and you see the response. If the blood glucose rise, that means there is a good store for glycogen, and that means this is not glycogen store. This is mostly hyperinsulinism. And for insulin levels that are more than 100 micro unit per ml, we have to obtain C-peptide. If the C-peptide is high, this is mostly insulinoma, and if the C-peptide is low, you have to think about exogenous insulin like factitious hypoglycemia. So there are some important points about immediate hypoglycemia treatment. You have to take the initial diagnostic blood sample before you go through correcting the glucose level, and you have to give like 0.2 to 0.4 gram glucose, which is almost equal to 2 to 4 ml per kg of 10 dextrose. And this is like a bolus, which is given at like in 4 to 6 minutes slowly. But then you have to start IV infusion of D10 at 10 milligram per kg per minute at the start, and then you adjust. If it needs more, you can go higher up with the concentration of the glucose, or if it is like now corrected, you go down. And the aim is to keep the blood glucose all the time more than 4 millimole per liter. That's almost equal to 72 milligram per deciliter. If the child remains unconscious despite normal blood glucose, here consider hydrocortisone, usually from 25 to 100 milligram IV according to age. Like in less than 2 years, you give 25. From 2 to 5 years, you give 50. For more than 5 years, you give 100 milligram IV. And if no response, think about intracranial disorder or import error of metabolism. And then you collect the next urine sample for diagnostic investigation. Newborns and small for gestation babies usually tolerating feeding, you have to increase the volume and frequency and give high calorie formula. What about the subsequent management? You have to continue glucose infusion. You have to reassess the air breathing, circulation, and stability, look for. And you have to correct electrolytes like sodium, potassium, and these things. And also, if blood glucose is still less than 2.6 millimole, you have to increase the blood glucose concentration from up to 12, up to 20%. But make sure that more than 12% is not given in a peripheral line. You have to use a central line because that to avoid extravasation of glucose in the tissues. That which will make hypoglycemia even worse. So if glucose required more than 10 milligram per kg per minute, think about hyperinsulinism. So hypoglycemia subsequent management also you have to have special treatment consideration, hypopituitarism and adrenal insufficiency. You have at the time of intercurrent illness, increase hydrocortisone 2 to 3 times. This is the stress dose of hydrocortisone. If there's increased like vomiting, diarrhea, fever, and these symptoms, you have to take care that you have to increase the hydrocortisone level so as to avoid the shock. In poor areas of metabolism, you have to give frequent high carbohydrate containing meals and avoid prolonged fast. In ketotic hypoglycemia, just like in poor areas of metabolism, you have also to add like uncooked cornstarch, usually mixed with a drink or a yogurt at bedtime, because at bedtime you will have like long hours of sleep that might prone the child for nocturnal episodes of hypoglycemia. So transient neonatal hyperinsulinism usually responsive to glucose and frequent feeds, and sometimes diazoxide. Persistent hypoglycemia of infancy, glucose infusion may need to be increased up to like 25 milligram per kg per minute. Most will resolve spontaneously, but some might need diazoxide. and chlorothiazide or somatostatin analog. We use it like sometimes like bridging medication, because the child will soon get tolerated to this medication, and they will be of no use after some time. You have to take like to do genetic counseling and mutation analysis for rectifying channels of potassium, and usually this is found in some mutations like KCNJ11 and ABCC8 mutations. Usually this can present like a focal or diffuse form of hyperinsulinism. And here you attempt diazoxide. If the diazoxide and chlorothiazide fail, you have to go for PET scanning. PET scanning, which is like a positron emission tomography, which is done to differentiate for a focal from diffuse forms of hyperinsulinism before going to pancreatic surgery, either subtotal or near total pancreatectomy. So here at the end, we will have like some case scenarios. So I will not just, I'll go through them quickly, but please like keep an attention for that, because they're very important. We'll explain more of the this talk. So a 2-day-old boy presented with sleepiness, jitteriness, and hypoglycemic convulsions. He required 20 milligrams per kg per minute to avoid hypoglycemia. When IV glucose was temporarily discontinued, the following results were obtained. Glucose 1.8 millimole per liter, that means 32 milligrams per deciliter. Cortisol 141 nanomole per liter. The normal value is more than 550. Growth hormone is 9.9. The normal value is more than 7 nanogram per ml. Insulin level is 72.4 millunit per liter. C-peptide level is 4, which is high, according to the reference value. 3-beta hydroxybutyrate is 0.45, which is within normal level. What do the above results demonstrate? So definitely here you have like required 20 milligrams, that means that more than 10 milligrams per kg. And we have here the glucose is still low, and the insulin is 72. This is very high. And the C-peptide is high. This is mostly hyperinsulinemia. Okay. So, and here we have cortisol. The cortisol is a little bit low, but usually is not strange to find this in these cases. You might find some cortisol deficiency, although you might need to go further to do like further testing for the pituitary pathway to make sure that there is no other issues with this low level of cortisol. Growth hormone is normal. So, are further investigations indicated? Yes, we'll check for the cortisol level, and we go for STH stimulation and see what is it. What additional therapy indicated? So here, this is hyperinsulinism. Usually you need to go for diazoxide and chlorothiazide, and for a while, or somatostatin. And if failed, you do PET scanning to see if this is diffuse or focal. Actually, we don't have this PET scanning service in Sudan, and many countries don't have it. So they go sometimes clinically. Usually, ABCC8 mutation is associated with a diffuse form of hyperinsulinism. So in many cases in Sudan, it's just like that. So we go for near or for total pancreatectomy actually, because if you do near total pancreatectomy, you might have still hyperinsulinism, and that might expose the child health to some fatality. So case 2, a 9-year-old boy came with 2-month history of recurrent abdominal pain, vomiting, and lethargy. On examination, ill, dehydrated, and hypotensive. Sodium 112 millimole per liter, potassium 7.9, urea 28.4, high, glucose 2.6, a little bit at the margin, cortisol 290, a little bit low. So what additional investigation need to confirm the diagnosis? So here we have to go, this is signs of hypotension and hyperkalemia and hyponatremia. This is mostly with these symptoms. You have to think about adrenal insufficiency, and mostly we are talking about Addison disease. What emergency treatment require? So for investigation here, we go for ACTH stimulation test to make sure that this is emergency treatment. Definitely, we need hydrocortisone. We need like salts, and we need also fludrocortisone. What further clinical signs may help establish the diagnosis? Definitely hyperpigmentation and these things. Okay. Case 3, an 18-month-old boy presented with confirmed hypoglycemia because the blood glucose was 1.7 millimole per liter, having refused bottle of milk at the night before, and also having awakened with vomiting. So he has, on examination, depressed conscious level, weight and height are just below the 3rd centile, no other abnormal findings. Sodium is 134 millimole per liter, potassium 3.5 millimole per liter, urea 5.8 millimole per liter, cortisol 1154, and growth hormone 8.1. So as you know, cortisol here is 1,154 is high, more than 550, and growth hormone is normal because more than 7 nanogram per deciliter. Insulin and C-peptide are undetectable. So what additional investigation necessary in this case? So from this scenario, it looks like with these attacks of hypoglycemia that usually present in this cases of bottle feeding milk, you have to rule out, you have to think about important errors of metabolism. You have to rule it out. This is very important. What emergency treatment require? You have here to give like glucose, because it's the blood glucose is where is it?
So, 1.7. In the first line, 1.7 glucose.
Yes, you have to correct the hypoglycemia. It's very important. And if no biochemical abnormalities of counter-regulation can be identified, what prognosis can parents be offered? Because if this is proved, there is no abnormal testing for the important errors of metabolism, you have to think about ketotic hypoglycemia or accelerated starvation. And here, just reassurance and follow up and give frequent feeds, and then you follow with frequent blood glucose monitoring and advise about night feeds to avoid like prolonged fast. Case 4.
Bashir, how many more cases do you have? If you can just...
This is the last one.
That's it. Thank you.
This is a 5-year-old boy was admitted for elective 20 hours fast after 2 days of discontinuation of anti-insulin therapy. He had been diagnosed as persistent hyperinsulinemic hypoglycemia at 1 year of age, following investigation into a 6-month history of convulsions. He had been clinically stable for 4 years on very modest doses of diazoxide and chlorothiazide with no hypoglycemia. His blood glucose was 3.8 millimole per liter after 15 hours fast, and he was asymptomatic all the time. Blood samples taken at the end of the fast were as follows. Glucose was 3.4 milligram per deciliter, insulin 3 milliunit per liter, and 3-beta hydroxybutyrate was 0.41 millimole, which is a little bit higher. And non-esterified fatty acids is 0.87, which is also a little bit higher. So what does this result demonstrate? Here you will find this is talking mainly about improving a case of hyperinsulinism. This mostly is not persistent hyperinsulinemic hypoglycemia of infancy, because although still insulin is still high, but we have here, like if you can see, there is a hydroxybutyrate is increased, and the free fatties increase also. So the management here, you have to stop diazoxide and chlorothiazide. and go for follow-up and frequent, checking of blood glucose, and see how is he doing after some time. And that's it. I think here we come to the end, and thank you very much.
Thank you very much.